ICD-11,6 C21, Body Integrity Dysphoria. Disorders of bodily distress or bodily experience. ICD-11, disorders of bodily distress and bodily experience encompass two disorders, bodily distress disorder and body integrity dysphoria. ICD-11 bodily distress disorder replaces ICD-10 somatoform disorders and also includes the concept of ICD-10 neurasthenia. ICD-10 hypochondriasis is not included and instead is reassigned to the OCRD grouping. ICD-11 body integrity dysphoria is a newly introduced diagnosis that is incorporated into the grouping of disorders of bodily distress and bodily experience. Body integrity dysphoria is characterized by an intense and persistent desire to become physically disabled in a significant way, for example major limb amputee, paraplegic, blind. With onset by early adolescence accompanied by persistent discomfort, or intense feelings of inappropriateness concerning current non-disabled body configuration. The desire to become physically disabled results in harmful consequences, as manifested by either the preoccupation with the desire, including time spent pretending to be disabled, significantly interfering with productivity, with leisure activities, or with social functioning. For example, person is unwilling to have a close relationships because it would make it difficult to pretend, or by attempts to actually become disabled have resulted in the person putting his or her health or life in significant jeopardy. The disturbance is not better accounted for by another mental, behavioural or neurodevelopmental disorder, by a disease of the nervous system, or by another medical condition, or by malingering. Exclusion, gender incongruence of adolescence or adulthood. Diagnostic requirements of body integrity dysphoria. 1. An intense and persistent desire to become physically disabled in a significant way, for example, a major limb amputation, paraplegia, blindness, accompanied by persistent discomfort or intense negative feelings about one's current body configuration or functioning. 2. The desire to be disabled results in harmful consequences, manifested by either or both of the following. Attempts to actually become disabled through self-injury have resulted in the person putting their health or life in significant jeopardy. Preoccupation with the desire to be disabled results in significant impairment in personal, family, social, educational, occupational, or other important areas of functioning, for example, avoidance of close relationships, interference with work productivity. 3. Onset of the persistent desire to be disabled occurs by early adolescence. 4. The disturbance is not better accounted for by another mental disorder, for example, schizophrenia or the primary psychotic disorder, in which, for example, a delusional conviction that the limb belongs to another person may be present, factitious disorder, or by malingering. 5. The symptoms or behaviors are not better accounted for by gender incongruence, by a disease of the nervous system, or by another medical condition. Additional clinical features of body integrity dysphoria. 1. It is common for individuals to describe their discomfort in terms of feeling like they should have been born with the desired disability, for example, missing a leg. Most individuals with this condition exhibit associated pretending or simulation behavior, for example, binding one's leg to simulate being a person with a limb amputation, or using a wheelchair or crutches, which is often the first manifestation of the condition. These behaviors are usually done in secret. The need for secrecy may result in avoidance or termination of intimate relationships that would interfere with opportunities for simulation. 3. Some individuals who attempt to make themselves disabled through self-injury try to cover up the self-inflicted nature of the attempt by making it look like an accident. 4. Many individuals with body integrity dysphoria have a sexual component to their desire, either being sexually attracted to individuals with certain disabilities or being intensely sexually aroused at thought of being disabled. 5. Shame about the desire to be disabled is common in individuals with body integrity dysphoria, and most individuals keep this desire a closely guarded secret because of a fear of being rejected or thought to be crazy by others. 5. It is common for the family, friends, co-workers, and even their partners or spouses of individuals with body integrity dysphoria to be unaware of their desire. 5. Some may seek treatment for associated depressive or other symptoms and yet not share their desire to be disabled with their health care provider. 6. It is assumed that most individuals with body integrity dysphoria never come to clinical attention. When they do, it is generally as adults, often when they seek the assistance of a healthcare professional to relieve their distress, to help them actualize their desired disability, or because they have injured themselves in an attempt to become disabled. Boundary with normality, threshold. Some individuals, especially children and adolescents, may have time-limited periods in which they pretend to have a disability such as blindness out of curiosity about what it is like to live as a disabled person. Such individuals do not experience a persistent desire to become disabled or the harmful consequences associated with body integrity dysphoria. Course features. The typical course is for the intensity of the desire to become disabled and consequent functional impairment to wax and wane. There may be periods of time where the intensity of the desire and the accompanying dysphoria is so great that the individual can think of nothing else and may make plans or take action to become disabled. At other times, the desire to become disabled and the associated intense negative feelings abate, although at no time does it completely cease to be present. Developmental presentations. 1. The onset of body integrity dysphoria is most commonly in early to mid-childhood, although some cases have their onset in adolescence. The first manifestation is typically the child pretending to have the desired disability, often in secret. Culture-related features. 1. Although apparently quite rare, cases have been reported in many different countries and cultures. Sex and or gender-related features. 1. Among those who come to clinical attention, males appear to be more common than females. Differential diagnosis. 1. Schizophrenia, other primary psychotic disorders, and other mental disorders with psychotic symptoms. 2. Obsessive-compulsive disorder. 3. Body dysmorphic disorder. Paraphilic disorder involving solitary behavior or consenting individual. Factitious disorder and malingering. Diseases of the nervous system, for example, somatoparaphrenia, in which a paralyzed body part is experienced as alien or as belonging to someone else. Please subscribe and comment.